This is also a tradition that in the last couple of meetings we have started with my lecture on patient selection and neuro-adaptation. And these are the keys in presbyopic refractive surgery. And I have no financial interest in Microsoft procedures in this lecture. Now, it will be general talk. What is functional vision? Functional vision is the ability to see clearly while performing daily activities in varying levels of light. So, you can see here on the slide, you have a normal functional vision and a reduced functional vision with poor contrast sensitivity. Snellen or any other chart, the EDGRS for example, does not take into account real-world situations of low contrast and low light. So here is a typical example of that. You could have a 20/20 vision clear, but you can also have a 20/20 vision blurred. Now which of the patients will be happy? Tell you. Now in my humble experience, good candidates with presbyopic refractive surgery have a strong desire to achieve excellent distance, intermediate and near vision without the need for spectacles. However, we must warn them that we cannot guarantee that they will have total freedom from spectacles. In the healthy eye, accommodation is aided by increased depth of focus through uncorrected astigmatism, longitudinal chromatic aberration, monochromatic higher order aberrations such as spherical aberration, coma, and trefoil. Age 60 and no accommodation. Why? How can they read? This is due to age-related changes in the pupil size, which is decreased, and spherical aberration, which is increased due to changes in the shape of the crystalline lens. We made an impressive improvement of treating presbyopia, but it is elusive to try to simulate the natural thing. And we are now moving away from what we tried to achieve with the laser supervision, 2015 or even better, to a functional vision or physiological vision, as I call it. And it's very clear that supervision is not optimal, because the guy with the supervision will have big problems reading, and that is due to he will have such a small depth of focus that even a mid-distance target will be a problem for him. You have to wash out for the patients who have a history of excessive complaints regarding their glasses or contact lenses. Drive at night as a professional, are happy wearing glasses, have pre-existing unrealistic expectations of visual improvement, problems with nighttime glare, and have pre-existing significant ocular surface disease. Now that is to say, my eye. The patient you have must be able to adapt to glare and halos, dysphotopsia. This is even common with ordinary IOLS. Immediately, and this you recognize, because you have been up to this every day in your clinic. Doctor, I don't quite think this worked. They can't see, they think. So managing the patient through the first initial stages post-op is the key to the success. And that is, of course, chair time. Ocular is a service disease I'm not getting into. We can speak on that for about 5 hours without interruption. But you have to check the tear film before doing your surgery. It's as simple as that. So how do we see? It's a complex interaction of optical and image processing pathways within the visual system from the cornea to the cortex. And image quality depends on inputs received through the eye and on processing in the visual cortex. Neuro-adaptation takes 2 to 6 months, and age is not, I repeat, not a determining factor. And above all, you need more chair time with these people. There will be binocular or monocular changes after surgery. And patients may obtain or negating an effect of an undesirable pattern. And this you also have to explain to them. The patient profile is the patient to undergo a modification in the visual system, whether induced by a new pair of progressive eyeglasses or bifocals, or by having undergone a corneal-related procedure or lens implantation with the novel optics or multifocal growth lenses, will undoubtedly be challenged by the newly created perceptive changes. And this is what we have to remember as well. Like spherical aberrations, we want to eliminate those. Now we have the yin and yang situation. It depends on willpower. It's a lot of psychology in doing the presbyopic patients. Does not work? Do not want it to work. It works and want it to work. It's psychological. The patient who does not want it to work or have discomfort will have discomfort. The patient that it works for will be very comfortable. However, very few patients want to see worse. They all want to see better. So natural vision is related to a great degree to the environment in which we are living and working. Plenty of examples of this on different distances. I've read some of them here, you can read them through. But if you look at the modern person today, everybody's using the phone. So a very, very common work distance now is about 50 centimeters. Maybe that's where we should concentrate, I don't know. So it is of utmost importance that we suggest to our patients that probably the best vision is not supervision, but functional or physiological vision. Customize the best overall solution for each patient. So the take-home messages, ladies and gentlemen, are the following. Considerations for choosing a refractive surgery procedure include patient preferences and patient age. Guidelines should never be binding law. Retain your ability to think further. Go outside the box. Patients may be more forthcoming about their expectations and demands when they are not in front of the doctor, but the nurse. Phrase your explanations to imply that correction at all distances may not be achievable. So reinforce the potential limitations of all procedural designs That is to say, a structural approach to patient selection maximizes patient satisfaction. So master a select few procedures as your premium offering and focus on two elements, visual quality and visual performance. Thank you very much.